Good afternoon, everyone. Welcome to today's webinar. We are allowing folks just a minute to jump on the line. We will get started in just a moment. Thanks for hanging tight.
Good afternoon, everyone. We're just going to turn on everyone's cameras here through the magic of Zoom, and then we'll get going. Thanks for joining us this afternoon. Great, the gang's all here. Thanks everyone for joining us on this webinar this afternoon. It's a terrific topic and a much more terrific panel of experts from a very wide range of perspectives on the topics that we're going to talk about today, which are lions and tigers and bears, vaccines, tests, and schools, among other things, as we talk about reopening the region's economy. I'm going to make introductions to our panelists, and then we've got a series of questions we're going to go through with the group, but a couple of housekeeping items. If you've got questions for us, please go ahead and use the Q&A function at the bottom of Zoom, and we are recording this. Some of you have already asked about whether or not you'll have access to the recording afterwards. We will send out that link as well. So let me get started with introductions to our panelists. As I said, it's a remarkable group, and we're really thankful to all of you for participating. First, I'd like to introduce President Sylvia M. Burwell. She's American University's 15th president and the first woman to serve as president. President Burwell has held 2 cabinet positions in the U.S. government, and those are, of course, particularly relevant for our conversation today. She was the 22nd Secretary of the U.S. Department of Health and Human Services, and before that, she served as the Director of the Office of Management and Budget. President Burwell has held leadership positions at 2 of the largest foundations in the world, including 11 years at the Bill and Melinda Gates Foundation, including roles as Chief Operating Officer and President of the Global Development Program. She then served as President of the Walmart Foundation. As we told her earlier, I think we're all looking forward to the book, because that's a remarkable range of experiences. Thanks very much, President Burwell, for joining us.
Thanks, JB. Happy to.
Great. Dr. Lynn Goldman is the Michael and Lori Milken Dean at the Milken Institute of School of Public Health at the George Washington University. Prior to joining George Washington in August 2010, she was a professor of environmental health sciences at the Johns Hopkins Bloomberg School of Public Health. Dr. Goldman was an assistant administrator in the EPA under President Clinton. She's a member of the National Academy of Medicine, and she chaired or served on numerous committees and forums. And we're delighted to have you here as well. Thanks very much for joining us, Dean Goldman.
Thank you.
Dr. Stephen Jones is President and CEO of Inova, the Washington, D.C. region's leading not-for-profit healthcare system, serving more than 2 million people annually in its 5 hospitals and numerous ambulatory programs. He's also a professor at the University of Virginia. Stephen previously served as president of Cleveland Clinic, regional hospitals, and family health centers. He's a renowned medical professional and has served as professor of surgery at Cleveland Clinic, Lerner College of Medicine at Case Western Reserve University as well. Dr. Jones, thanks for joining us.
Thank you.
And Joe Ucuzoglu is the Chief Executive Officer of Deloitte. Deloitte has over 100,000 professionals and, as you know, serves as audit and assurance, tax consulting, and risk and financial advisory services to a broad cross-section of the largest corporations and governmental agencies. Deloitte has been particularly involved in the topic we're going to discuss today with a variety of folks around the country. And so we're delighted to have Joe join us. He serves on the board of directors of the U.S. Chamber of Commerce and the Partnership for New York City, and he's also on the partnership, the Greater Washington Partnership Board of Directors. Joe, thanks for joining us.
Pleasure to join, JB.
Great. Thanks, everyone. I am now going to go through an incredibly fast zip through of a series of scene setting slides for folks so that we have some content to discuss that we can share. Go ahead, Jenna, if you would. First of all, we've launched today a clearinghouse of information about recovery. Much of the material we'll cover here, and a very broad range of other material is available at that clearinghouse. We'll add into the chat room a couple of other links as well. We had done a reopening survey for the region a few months ago. We're doing that again to get a sense of the pulse of the place in terms of when organizations feel they can reopen and what the issues are for them to reopen. But check out the clearinghouse if you've got any questions about any of the material. It's a quite rich resource. Next, please. I wanted to start by sharing some information that was shared with us, some of us last week by the White House's coronavirus task force. The first, of course, many of you have seen, but we're in the darkest part of the tunnel in some ways, albeit a part of the tunnel where there's greater and more clear light ahead. As this graph shows, the rate of increase in cases nationally is faster than has been the case at any point since the beginning of the pandemic. Next slide, please. These are some points that Dr. Bricks, who is on the task force, shared with some of us last week, and I just thought I'd quickly go through these because I think it's an important context for all of us to share. First, the surge is deeper and rising more rapidly than we've seen previously. It's broader. It is, any of you have seen those maps, it is happening everywhere simultaneously rather than concentrated in fewer places. It appears to be longer in duration, and I think one of the big concerns I'm hearing from healthcare professionals is that we don't know how long the duration is going to be. Excuse me. The hospitalizations, of course, are following cases, and deaths are following hospitalizations. All of this prior to the holiday season. Interestingly, the White House has been calling recently for the bullet points on the bottom here. The key to stopping and preventing future surges is proactive testing, finding the asymptomatic silent spread before the vulnerable become infected. That is a new position on the part of at least a new public position on the part of this White House, and one that I think many of us welcome. Finally, Dr. Birx made the observation last week that testing needs to be increased by a factor of 10 to be able to both test for asymptomatic and symptomatic infections. Next slide, please. Just to give you a sense as to what that factor of 10 might look like, we're testing at roughly 1.8 million a day. Currently, some, including Nobel laureate Paul Romer, have called for up to 35 million tests per day. We were on a call this morning with the CEO of Thermo Fisher, who argues that we actually have capacity to do 10 to 11 million tests per day. Currently, we have that capacity, but that we're only actually, as you can see, running a small proportion of those. So to the degree that we're calling for broader testing, we have a pretty broken system right now. Next slide, please. This was a slide that was delivered to us by folks in New England this morning, and it's a call for national action on testing, and it's one that we certainly at the partnership subscribe to as well. I think what's interesting is that you're seeing regional groups. This is the Massachusetts Tech Council, which has been central to efforts in Massachusetts to respond to COVID. You're seeing groups like that make this call now, and we're hearing it as well from both this administration and the next. We'll come back to that during the conversation. Next slide, please. So that's the tunnel and some of the things that we feel could and should be done to address the circumstance we're in. The good news, of course, is that there are a range of vaccines that are developing. I won't go into all the detail other than to say that this is a list of the hottest contenders. 3 have come forth with early data, which is quite promising, albeit the AstraZeneca data is a little bit confusing. The US has pre-bought, for lack of a better term, about 710 million tests for next year from across these various providers, roughly half of which are from AstraZeneca. So we'll talk more with this group about what the path for vaccines, both their development and their distribution means in particular for the region. But clearly it's good news. Next, please. Sadly, part of the reason I shared this slide just because we were struck by it last week, part of the reason why these trials are moving forward so quickly is because the number of cases has gone up so dramatically. Moderna indicated that they were able to get the results about a month ahead of what they had originally planned because there are so many cases. So it is a dark time, but it's having some benefit with respect to the pace at which these vaccines can be trialed. Next, please. Two quick things. Again, we'll talk about this. One is, for the most part, as best we can tell, the trials have not been testing for whether the vaccines have any impact on asymptomatic folks or on the ability to transmit. That can have repercussions if we don't know that. There will be efforts, I think, to understand that. We'll talk further about those. But I think it's summarized in the third bullet point here, which is that folks are still going to need to wear a mask through the year. We're still going to need to engage in social distancing of various sorts. And we're going to need testing through the year, even with all the great news about vaccines. Next slide, please. Quickly on distribution, the national academies have issued recommendations as to phasing of the distribution of the vaccines. The ACIP discussions, which we'll get into, I'm sure, in a little bit more detail. We'll talk to those after the EUA reviews. Some on this call know these processes very well. But I think the essential thing here is to understand that given the volume of vaccines that look like they're going to be up for early EUA, we're only going to be able to vaccinate a subset of the population over time. And let's go on to the next slide, please. This is a graphic way of representing that, but this will then lead to my next question. Given what we know, and of course all this can change, it does look like certain substantial segments of the population, I'm thinking, Joe, of the folks that work for you, many of whom are in their 20s or 30s, or Dean Goldman and President Burwell, the folks that are going to go to your universities in the spring and the fall. They're going to be at the tail end of the distribution of the vaccines. So one of the points of conversation I think they have with this group is if that does look to be the case, then what are some of the implications for thinking about reopening? So I wanted to share that with the group. Those slides will be available. Thanks very much for putting those up. Now let's call the panelists up. Great. And I've got a series of questions. Again, I'd encourage anyone in the audience to go ahead and drop questions into the Q&A. But let's start. I'm going to start with Dr. Jones. You're leading one of the primary healthcare systems in the region, and you're a renowned physician. What's your take at the moment on the path for vaccines this year? And then talk to us a little bit about some of the challenges that the mRNA solutions represent and how Inova is going to be dealing with those, because those are like the first two that are going to be out of the box. Thanks.
Thank you, JB. And indeed, that does appear to be the case. We still don't know. Lots of assumptions are being made on these right now, but let's assume that they get the emergency approvals and that we will have 25 million doses of at least the Pfizer vaccine by the end of the year. I think that the good news is that I'm as excited as I could possibly be at this point compared to where I thought we would be with the development. Having said that, until they start arriving, we won't be sure. We expect to have a trial run within the next week or so of a fake box, if you will, to make sure we run through all the different things that need to happen. But assuming that goes well and the supplies there, we anticipate being able to give the vaccinations to some of our frontline team members, hopefully before the end of the year. You've already alluded to the fact that there aren't going to be anywhere enough, but our healthcare workforce right now is critical to the entire country. So leaving them able to continue to work and have less likelihood of exposure is going to be, I think, a very significant move. The last piece is that these vaccinations are complex to administer. low temperatures. The good news is we've all stocked up on these low temperature freezers. The bad news is we've never had to have these type level of freezers before. And so we feel very prepared to do it. But I do think that in certain parts of the country where they don't have the resources, it may be a real challenge.
Great, thanks very much. And one question, just a quick subsidiary question on that, Dr. Jones. What's going to be the role of the doctor in determining who gets a vaccine when, or is that going to be up to the doctor?
Well, right now it's going to be up to the states, which is not, I think, the approach that we should take. I'd rather have a national approach to this than state by state, but it appears to be what we're going to be stuck with. And so there's a possibility that even in the 3 jurisdictions that are all within hearing distance of my house right now, we may have different approaches. Having said that, I think it's very clear that hospital workers, especially frontline hospital workers, and certain first responders are likely to be prioritized in every jurisdiction. But there are a number of other folks who we really want to keep on the front line. So, for example, behavioral health specialists, recognizing that crisis going in our country, I will be advocating to have those folks be able to have access as soon as possible. To the specifics of the role of the physician, we are the second most trusted voice in healthcare recommendations, right next to the nurses. And I'm concerned that some of our colleagues are anxious about their confidence in the vaccines currently under development. I think as soon as we have the science, it'll be a critical conversation on the part of the thought leaders. I'm hopeful that the physicians and nurses will be enthusiastic supporters, because the unfortunate negative perspectives towards vaccines has been tragic in this country, and it faces the risk of being even more tragic in the near future if that affects people's willingness to take these vaccines.
Great, thanks very much. Dean Goldman, you've been involved in processes like these, of course, in the past. And to Dr. Jones' point, I know, for example, the District of Columbia has put K through 12 teachers and staff into phase 1B, to use the National Academy's phasing. So they've already taken a bit of a different position. Really, 2 questions for you. How are you thinking about what those phases will look like? I know everyone on this call is thinking, when will I get my vaccine? But also, you and I have talked a little bit about what the psychological response may be as the vaccines are rolled out, which might affect behavior as well. Could you speak about those, please?
Sure. Well, first and foremost, I think 1A is likely initially to be kind of maybe even microphased. I mean, we're talking about a GW, and I'm sure this is true in Inova as well, that if we don't have even enough for all of our healthcare providers, who are the ones who have the most potential exposure to aerosols from patients, who are most vulnerable because they're older or they themselves have chronic diseases. They're also human beings who are variable, and so, so at the very beginning, we're going to have to really, we probably won't have enough for all of them. We possibly won't. We aren't going to care about where they live. We're going to figure if they work in DC, when we get the DC doses, we'll dose them. And I'm sure that's what, they're doing in Inova as well. But you're right. I mean, we actually wanted to see the teachers moved into that group of frontline workers. And the reason for that being that even so many healthcare providers can't work if their kids can't go to school. The reality is that many healthcare providers are married to other healthcare providers, and that you have a whole household where somebody has to be at home if their kids can't go to school. And so I think this is a very important decision that DC has made. And I hope that the other states look at this as well, because just the practical reality of being able to leave your children. And that's another piece of this. And to your second question, JB, as a pediatrician, I've been particularly worried about the fact that children are very rapidly developing. Their minds are developing. And we know there are times when they have great language receptivity, for example, and when it's right to be teaching reading and teaching language, even foreign languages. There are times where they have great ability to learn quantitative concepts and to develop in that area. And if they're at home during that time trying to learn on Zoom, and they're pretty darn young to be able to do that effectively, they're not like college students in that regard, then they may be experiencing a delay. in their education that is difficult to overcome later. An 11-year-old can't learn like a 9-year-old, and they can't learn like a 7-year-old. And so I think that it's urgent to get kids back in the classroom, and the younger they are, in my viewpoint, the more urgent it is. So, you know, I'm excited, I have to say, that there are 3 vaccines that may be delivered here. But I guess as another piece of that, it's a little bit confusing, I think, right now. Not just that there is resistance to the vaccines themselves, but the differences among them. You know, which one do you take? If you have one, then your booster has to be that same one, right? Not a different one. And so getting in a program where you get the same one twice, how are we going to keep track of all those people? So one of the things that we know in implementation is that, you know, many times, you know, like with families and stuff, we use little vaccine cards. That's not, you know, 21st century technology. We really ought to have a way of being able to reliably keep track of not only who got which one, but which batch they got, you know, because, you know, that it can come down to that as well. And we're seeing that with what we heard about the AstraZeneca trial, that, you know, these things have been moving out really rapidly. And so I hope that we get help from our friends in tech to be able to do better, you know, excellent tracking of that. You know, people will get they might get it in within their healthcare system, but they might get it somewhere else, at a pharmacy or somewhere else. So how you connect those dots, and our systems don't work very well together.
Right.
So that's all going to be a challenge.
Yeah, well, thanks for that. Joe, let me turn to you. I know we've talked a lot about how business is thinking about some of these issues, how schools open or not open affects businesses' ability to reopen. Can you talk a little bit about what you folks have learned about issues like that, and also the role of testing as organizations think about reopening? Thanks, Joe.
JB, we're having this conversation at a pretty fascinating time, and just speaking from the kinds of questions I get from our own people, which is probably pretty representative of the population at large, it's hard for people right now to reconcile how much terrible news there is and how much great news there is, and trying to put this in perspective, that it's really a matter of building a timeline, that things are probably worse in the near term than people had hoped they'd be. And that's not going to change overnight. But that at the same time, the path out of this over the medium term looks so much more promising, given the early results across a variety of these clinical trials here in terms of efficacy levels. And so when you then translate that into what's on the mind of the business community, we have been far more effective at accomplishing white collar work virtually than anybody thought possible. When you go back to the beginning of this pandemic and the dire predictions in terms of what this would mean across the entirety of the economy, and there are certainly portions that have been adversely impacted with dire consequences, but all things tech enabled, all things white collar have held up quite well. And so, there are some who might not have the absolute urgency, it has to be tomorrow. But on the other side of the spectrum, when you think of this through a societal lens, even if we and some other organizations that fill these big towers in city centers can continue to accomplish our core mission remotely, what about the whole ecosystem of businesses that's reliant upon us, upon our people being there in person, that's struggling to hold on, that may not be there if this persists 3, 6, 9 months longer? And so there's a real societal obligation element to this. And then even within the confines of the business community, yes, we're effective at carrying on our core function, but there's clearly some drop-off that increases over time when people have to be 100% virtual, zero co-location, the ability to drive breakthroughs, to innovate, to co-create with clients. That stuff we're doing the best we can over technological platforms, but it's not as good as being able to at least be together for part of the schedule. And so there is at least some sense of urgency to be able to get some form of in-person interaction back into the overall mix of the work week, but you can't do it when schools are closed and the employees have to be home. You can't do it when you don't have confidence in public transportation. You can't do it when overall people have a fear about those who they're interacting with. And that's why we've had such a focus on testing. And we know in selected environments where Deloitte has partnered with local communities that there is success in scaling up capacity and in using that as the vehicle to give confidence to bring people back. And there's no doubt that prioritizing K through 12 is a necessity, both from the standpoint of what kids are losing out on relative to educational outcomes, from an inclusion perspective, the adverse consequences to those who are less digitally connected, and then the domino effects that if the kids aren't in school, the healthcare workers can't go to work, those in the office buildings can't come in, which is why it's so important that testing connected with getting K through 12 education online is an enabler to all the rest.
Yeah. Joe, that's great. Everyone's in violent agreement. So I'm now going to turn to President Burwell. Obviously, and I'm going to ask sort of an indelicate apolitical question, but we seem to have a point in time when the Biden transition team, the current, at least some of the current administration, and then leaders like the ones here, all agree that with some of the steps that we should be taking on a consolidated basis. If you were responsible again for HHS, and I'm not proposing that, no one, that's not breaking news, anyone, but if you were, or if you were influencing the transition right now, what should we have HHS, the CDC, the FDA be focusing on? Because one of the issues seems to be that there has not been a national plan. Can you share your thoughts on that?
So I've articulated before that I believe a national strategy and a national approach is what we need as a nation, and that'll have a number of different elements to it. And it gets to Joe's point about we are in a challenging time, and the vaccine is coming and on its way, but you need a national strategy against all pieces and parts, and you need to focus on what are the tools that we have in the toolkit right now. And those are basic public health tools, and that is, the masks, the hand washing, the distancing, and the testing, isolation and quarantine as well. And so how you make sure that there's a national approach so people know when to use these tests and when to use the things. And information, it continues to evolve. And so we need to depend on NIH, FDA, CDC to provide the scientific information of our best knowledge of how to use those tools. And at the same time, we have this other tool that's coming on, and that's the vaccine. And we need to think in terms of that tool being an additional tool. The strength of that tool grows over time. As more and more people get vaccinated, the strength of that tool grows. But we need to be there needs to be a national strategy and approach to all of those pieces. And we need to be in a place where we're providing as much factual information as we can on a day-to-day basis. And I think if we can get to a place, we're in a very challenging time in terms of, I think we have to start with the number of deaths and hospitalizations as well as cases. I think focusing on those two very important things, because those are critical path issues as we think about the future. How do we use the tools that we have to get things in a better place as we move to the place where that very strong tool comes in line? But that is a strategy and a national approach with guidance, as Stephen was mentioning, in terms of you need different pieces of guidance, and Lynn mentioned that too, so that at the state and local level, people have the information they need. What's different about a pandemic that is different from other crises that we as a nation face is that actually everybody has a role, in the sense that in order to be successful as a nation, and Joe was talking about it in terms of the business perspective, but that broader perspective, but each of us as individuals. And so it has to happen at our national government level, and we need to be coordinating around the world. If others coming up with vaccines, treatments, or other things, we want to get those. And it needs to go all the way down to the citizen so that we all can do our part. We have the information we need and the tools we need, and a national approach to that, I think, can get us there.
Great, that's great. And I'm going to come back to the question of sort of how civil society can help through this period, because one of the concerns we're hearing is that everyone feels that the vaccine cavalry and the Biden cavalry are coming, and so we can all just sort of sit back now and not contribute. And I think what I was hearing you say is, no, in fact, it's more critical than ever that that all of the constituents and all of the groups participate. That's a good segue though back to Dr. Jones. And Dr. Jones, a couple of questions for you. One is, how is your staff holding up? And then related to that, how are you looking at the demands on your staff given this huge surge here? And what are you doing, or what can any of us do to help mitigate some of those demands?
Is what can be done, I think, has already been talked about here. Where, wear a mask and don't rebreathe air, and clean our, keep our hands clean. And unfortunately, we're not all doing that. I think President Burwell's point is really spot on. This is all of us. So you can protect our staff by not coming and needing COVID care. I think how the staff are doing is a tale of good news, bad news. The bad news is they've been working at this for months, and they're overwhelmed, and that every American has stress upon us. The healthcare workers probably have just a little bit more, including the fact that they're responsible for those who get ill. The good news is that early in the pandemic, I had absolute confidence in the Inova staff's capability of handling an unknown disease, and I will tell you that I underestimated them. That despite all the stress and all the things such as having to have their kids at home, family issues, mental health crisis is now its own pandemic, if you will. Having said that, they keep coming in every day and taking extraordinary care, and I think that's probably going on in most of the healthcare institutions in the country. These are special people who go into it, and they don't let it get them down as much as you would expect. But they are under significant stress, and everything that we can do at Inova to help with their resilience, we're trying to do. It's really probably my greatest focus right now is on the resilience of our workforce.
Yeah.
You ask about, what's going on. We've seen probably an almost doubling in the last 2 weeks of hospitalizations in Inova, and that's not unique to the rest of the country. It's very important to recognize that, unlike in the spring when there were places, including here in Greater Washington, where we had a significant surge, at that time, people from around the country could come in and lend a hand. Not that we needed it that much here, but certainly New York did. Right now, there's nowhere for anyone to come from. So it's really critical for all of us to take our responsibility and not need hospitalization if we expect to be able to get through this without concerning things happening. And when I say that, JB, the concerning thing happening is not just COVID. It's the people who are not coming in for other care. We've seen tragedy after tragedy of strokes and heart attacks and unscreened and untreated cancer. So this is building up over time. And so I hope that people will take the advice in this discussion very seriously of keep yourself out of the hospital, because there are others who will need non-COVID care who will be at risk of not getting it if we get overwhelmed.
Yeah. Thank you. I'm going to turn the conversation to two other topics, and then I wanted to go to a bit of a longer term perspective. I wanted to go back to talking about kids and public schools, and I wanted to ask President Burwell and then Dr. Goldman just talk a little bit more about the effect of keeping schools relatively, public schools in particular, K through 12, not open from your point of view. And I guess as context there, and I'm open to having anyone challenge it, as best I can tell from the suggested distribution priorities, kids and potentially the healthy families of kids are going to be relatively late to be vaccinated. And that could well be, we don't know, but it could be summer, even prospectively later. So President Burwell, let me start with you. What are your thoughts about kids in public schools in light of what we know and what we should be thinking and doing?
So in the context, I have an 11 and a 13-year-old who are doing that learning from home. And when talking about K through 12, the importance of doing this, I think, has three different categories, I would say. Number one is mental health and health. We'll talk a little bit about that. Number two is education. And number three is economics in terms of as we think about the importance of K through 12 schools. Starting with the health issues, we know right now in terms of the children, as Dr. Goldman was talking about, as Lynn was talking about, important in terms of kids, not just when they learn different things, but the developmental part of being with others. And they are social, we are all social beings, but our children are especially so. And so the idea of the importance of them being around other children and being face-to-face in terms of that learning and the mental health issues that we're going to see, as Stephen just mentioned, I completely agree with him. And I think both mental health and the care that we're not doing will be the thing that follows right behind as we get things improved with COVID. So number one is health of those students and thinking about that. Number two is education. And Lynn spoke to that a little bit, but I think we know, and we're starting to see the analytics that show our children are getting behind in terms of their ability to do that learning. And that is not a comment about the incredible effort that so many teachers across the country are putting into trying to do it by Zoom. But it's hard. I have an 11-year-old and a 13-year-old trying to do it every day, and it's very challenging for kids. And my children have many supports and resources in terms of the family and the setting that they have, and that brings me to economics and the third issue. And I think Joe was touching upon that in terms of the ability of our workforce to be able to reach the levels of productivity, even if they're at home doing that, doing it from home for those white collar, but the strain that it's putting on those who cannot do their work from home. And so it has an economic impact as well. So focusing on that K through 12 and making sure we do everything we can to create the safety that is needed for the teachers, for the students, for those that work in the schools. And that is why testing has been such an incredibly important thing to do.
Yeah, I appreciate that. Thank you. And I know someone on the call's got a dog. I'm just telling all the audience that you can't have a Zoom without at least one dog and or a young child zipping in. So thank you, whoever provided the dog. Dean Goldman, what are your thoughts on that topic?
Well, I should start by confessing it's probably my dog, who I've discovered since Zoom is actually a diva, who uses every opportunity to perform for an audience. So I apologize for that. And there she is.
That's wonderful.
Just because I said the word DOJ. Okay, so, I think that the thing that we have to realize is that whereas students and especially younger people are very involved with the transmission of the COVID into communities. And in fact, there's great evidence that transmission in schools among school-age children is followed by a wave of transmission among people in their 20s and 30s, otherwise known as probably parents of the children, which is then followed by waves of transmission to even older people, often probably grandparents and others. That we do have to be concerned about the in-school transmission from that point of view. But the risk is by and large not personally to the children. Children are at some risk, and I, as a pediatrician, take that risk very seriously. There have been children who have died from COVID, who have extremely severe forms of it, but that is rare. More commonly, the risk from transmission for among children is the risk to people of older generations who are impacted because of the spread of COVID into communities, because of the spread that happens in schools. And any parent of a kid who's been in daycare knows about that, knows that when their kid is in daycare, that they have many, many respiratory infections. They bring them home and you, the parents, are going to get it. And that's not so bad in a normal circumstance, but it's terrible when it's a virus like COVID-19. So I think that one thing that's going to change the equation dramatically is when those older people in the community, members of the family who are more at risk of chronic diseases who are older, even before children are immunized, when they are immunized, that is going to change not just the perception of the risk, but the actual risk level of the transmission in children. I do agree we're going to have to continue to have a lot of hand washing, wearing masks, distancing among the kids because they are also at risk. And it may well be that it'll never be okay again in our society for people to go to work or go to school when they're actually sick, when they're actually coughing, sneezing, creating droplets that, our old way of treating with anti-fever drugs, with decongestant drugs. We may not want to do that anymore. It may be that, like countries in Asia, that we will continue to wear masks when we have respiratory infections. Beyond this, we may be seeing a shift in how we manage respiratory infections more broadly, because it's also possible, and we haven't talked about this very much, but it's possible that we won't be able to eradicate COVID-19. It's possible that it will wind up being one of the many respiratory infections that's circulating in our population, possibly every winter, like the common cold, which after all does include other coronaviruses that are quite similar. And because the immunizations are not going to be 100% protective, that even when we have some form of herd immunity where we don't have massive outbreaks like we have now, we will continue to see circulation, which can be quite dangerous to some in the population. So this is a long way to say something that I think is important, and that is that even before the kids are immunized, the vaccine is going to be a game changer because it will reduce the risk in the population, the risk of kids transmitting to their grandparents and others who are more vulnerable. Eventually, they will be immunized and the risk will go way down, but we may be continuing to control this virus for a very long time, if not forever, if we can't actually eliminate it, as we could with SARS-1 and MERS, which we were able to eradicate. This virus is far more difficult to manage, and so remains to be seen. But I think it's quite possible that it will continue to recirculate over time.
Yeah, well, thank you for that. I'll be wearing my mask on my transcontinental and international flights, I think now, as my colleagues from abroad had been prior to all of this, probably for the long term. Joe, let me flash forward a little bit. If you knew that 70% of your employees weren't going to get vaccinated until December of this next year, so 12 months from now, what would you do in the interim? And then a second question is, how different is Deloitte going to look in terms of, how many facilities you have, et cetera, when things are quote unquote back to normal?
Well, I know you asked a hypothetical. I'll tell you, based on the advice I've been getting, I'm a little more optimistic than your next December projection. But whether it's spring, summer, early fall, there's clearly a period of time before we have widespread vaccination that gets you to the point of some form of herd immunity, and we all have to make decisions about how to operate in that intervening period. Right now, substantially all of our people work from home. Our offices aren't home, and even more significantly, we're in the business of serving clients, and substantially all of our clients have asked us to do our work remotely, not on their premises. If, as we come out of this current phase of the pandemic, even before widespread vaccination, there is an ability to get the spread under control, then we would certainly consider making available as an option to our people some form of on-site work. Unlikely that we would make that mandatory. We'd want to respect the choices of individuals in different life circumstances, but we're not going to do that while there is continued high levels of community spread. In terms of, well, what does the working world look like post-COVID, whether that's completely eradicated or at least sufficiently under control that we don't have significant community spread once we get to a scaled up vaccination rollout. There's still going to be some significant learnings that come out of the last 6 to 8 months that don't go away. Now, the views of our people span a pretty broad spectrum. We have many who would say that this has been incredibly hard on them, significant mental health issues as a result of being more isolated, not being able to be together with colleagues and clients, and we're doing a lot to everything we can to support our people through this period of time. We have people at the other end of the spectrum who would say that they're actually quite pleased with the ability to work from home, that it's been great for their own balance, less time spent commuting, more time with family? Can I work from home permanently? Now, those people don't tend to be all that vocal because you don't want to suggest that you're sitting there and having this wonderful experience when so many are suffering and in dire circumstances. But there's absolutely people who prefer this method of work. And then you have everywhere in between. I would suggest that we will land long-term somewhere in the middle, that we will recognize that there are important times to co-locate, and that we will make those times most impactful when we do get together, but that we also take advantage of what we learned the last 8 months, that there are chunks of work that can be done effectively on a remote basis, and that giving people additional flexibility, the ability to spend less time commuting, to fit their work into their personal lives, to reduce their overall footprint on the environment in terms of commuting and travel, those are good things that we don't want to lose. And so whether this is ultimately 50-50, 40-60, 60-40, there will be some hybrid optimized blend that I would actually say takes the best of both worlds. The best of flexibility and remote work for part of the schedule, and the best of in-person impactful experiences for part of the schedule. And the light at the end of the tunnel here, it's actually energizing to our people that we'll have a better way of working going forward.
Great. That's great. I mean, one of the things, if we have time, we can talk about, you alluded to this, Joe, but sort of the impact on businesses around your businesses, right? If as that mix shifts, if you look in DC, for example, small businesses have just been decimated as the city's been quite careful in response to all of this, and that can continue depending on what that mix looks like. I wanted to talk specifically about testing, and then we do have a number of questions from folks that are watching, and I want to get to those as well. But one of the things that's come up very frequently in the last few days is this view that we should have an Operation Warp Speed for testing, that we should have had one, but we still should have one. And the question, and I'll start with you, President Burwell, is it too late for that? Joe, for example, just mentioned that he's getting feedback that it may be sort of spring, summer, at which his folks can largely be vaccinated or have sufficient access to vaccinations. Lynn, you were mentioning that there's going to be this sort of psychological tipping point where enough of those who are at greatest risk will have been vaccinated that people will probably feel. Is it too late to really stand up an effort like that around testing, or should we be doing that? President Burwell?
I think in the current context that we're in, with the number of deaths and hospitalizations of a highly transmissible asymptomatic disease, that the answer to that is most certainly yes. We need to, when we look at the death rate, and while the number of people that die from COVID, fortunately, has continued to come down in terms of the percentages, because we have so many cases, we have many, many deaths in our country, around the country. And so that, combined with the hospitalizations and the pressure, the testing, as Stephen was saying, can everybody please do what you can so that you aren't coming, so that we can take care of both COVID patients as well as those with other things that need to be treated. So I think it's not too late. I think it's important. We're in a stage and a place, we know we're going through the Thanksgiving holiday season. We will go through the Christmas holiday season. We will then be in the hardest time to do things outside for the next 3 months. And so having that testing capacity as another very strong tool in the toolkit. What I think we're in a stage right now where we need to be using every tool in the toolkit to the maximum ability of execution, both from the level of the federal government to businesses to all kinds of institutions to us as individuals, and that's how we'll more quickly move through and get to that other place. So I would say, yes, we do need that. And I think what that will do is that will tell us in your slides and charts, the question of how many tests are available. If they're not moving, then is it a matching problem? When you have that level of focus on the level of details that you need, and it also focuses on the fact that you need tests that are easy to use, easy to access, and fast in terms of giving people the results. The one thing we need to do as we move towards this effort and focus on testing is to continue to emphasize that a negative test is not a license to not do the other public health measures. We're in a place and time where what you need are the combination of tools to get to the best place that we can.
Yeah, that's great. Dr. Jones, let me turn to you. What if there were a federal or regional kind of Operation Warp Test, to use a terrible dad joke, but how would you, running a healthcare system, regard that? What could that kind of an effort help? How could that kind of an effort have helped or help you? Because obviously you've had to stand up a great deal of testing capacity kind of in the breach. Any thoughts on that?
Well, one is that we've spent way too much of our time trying to develop and get access to multiple testing platforms, time that could have been spent taking care of patients instead. And so it continues to be as big a challenge, or almost as big a challenge, as it was back in May, candidly. I think the second is that, as Sylvia said, it would have kept people out of the hospital, had we had access to that, would allow people to travel reliably. I took a vacation in the summer to Maine. We rented a cabin in the middle of nowhere so we could be by ourselves, but I needed a test ahead of time. It took 3 days, and we're not that much better than that right now. So I think that the fact that it goes with so many other things, the fact that we aren't working together on a national level to have one approach to solving a problem, we know that that's how you solve complex problems. And so these conversations are how we get closer to having that same approach for all of us.
Yep. Thanks. I'm going to turn to questions from the audience, and you will excuse me for squinting into this little tiny chat box on my computer screen for a moment, folks. We had a question about congregate settings and the stigma versus science of prioritizing their vaccinations. I guess the way I would interpret that question would be, if we're going to prioritize vaccinations for folks in congregate settings, and maybe this is a socioeconomic question, sort of not necessarily the elderly, but if you think about a lot of the essential workers who are living in home circumstances, which are quite close, quite congregate, how do we signal that getting vaccinated is okay to some of those populations that we're going to want to have? And what can, I guess, just to broaden the question, what can civil society do to do that rather than just wait for federal response? Any thoughts on that question? That's a jump ball. Yes.
I have a thought about it.
Please.
This is something that's always an issue in public health, which is the transmission of any communicable diseases in congregate settings, which, by the way, broadly include residence halls and universities, which is part of why we've been so much in the forefront with testing. Because in reality, we have young people who are highly social who are in congregate settings. But also in what we've seen certainly in assisted living facilities, we're seeing also in congregate settings like prisons, a tremendous amount of transmission. And it's so important from the standpoint of public health, because that transmission in those settings amplifies the epidemic into communities. And in fact, when you look again and again at the spread of the COVID-19 across our country, and part of why we have such a high peak that's happening now, is that the infection gets seeded into communities through these congregate settings, which then provides, if you may, the spark that can set it off in the broader community. So you don't want to be identifying those communities as a way of stigmatizing them. It's not the fault of people in those communities. I feel sorry sometimes for our students, because I think sometimes even young people have been stigmatized in the media when there are reports of, well, there's a lot of transmission among young people. There's a lot of transmission among people in their 30s, their 40s, their 50s too. Everybody's transmitting. We are in a major pandemic. And but the truth of the matter is that as to control the epidemic, to find those places where the epidemic is accelerating is important in terms of focusing on control of it there, whether it's more testing, immunizing, or making sure that the behaviors are more appropriate. But the other piece of that as well is to not then say, well, that means that everybody else is okay and we don't need to take action in those places. Honestly, we had a reverse problem earlier on. I don't know about President Burwell, but certainly on my campus, initially many of our students believed that this was just a disease of older people. And so, when you create a stigma and you create a kind of a stereotype of people who have the disease, you can make other people feel they're safe and that they don't need to take measures to control it. And the reality with this one is that none of us are actually safe. We all have to be engaged. And that goes to, well, again, earlier, it was just a disease in cities. And many of the small towns and rural areas that now have a lot of transmission thought they were safe. And so this issue of stigma, I think, is very important, that we don't communicate in a way that either makes it seem that we're blaming people, who are transmitting the disease, or even worse, saying that others are safe and don't have to take action to protect themselves.
Thanks. Let me sort of turn that question on its head. And Joe, this is back to you. But if you think about, there is talk about immunity passports that, some companies may, for example, require their employees to show proof of immunization to get to access a workplace. So the question for you, Joe, is how do you think about something like that in your context? And then the question for the group is, should we have something like that? If there may well be settings where which can't open if you don't know that everyone in that is immunized. I'm thinking, my daughter is a stand-up comedian in LA, and who knows when they're going to get back to work. But Joe, thoughts on immunity passports in the context of the workplace?
I think there's going to be a fundamental, philosophical dialogue around, how much of this is carrot versus stick. You always prefer the carrot, but recognize that you may need some stick. We have a massive undertaking to build confidence in society at large to take the vaccine. And that's probably a challenging task in any environment, but we're going to be doing it in the midst of perhaps one of the more polarized environments in a generation. And so getting a wide cross-section of advocates here, not just experts, not just government officials, but individuals with pop culture recognition, individuals who will widely resonate with a broad cross-section of the population, is going to be critical to building public confidence. And you'd like to think that's going to be a big piece of the puzzle. Then you get to the question, well, how much of a stick do you need? How much does it become a requirement? And some of that's going to have to come from sort of government policy relative to who's allowed to do what where. But there will be consequences. Undoubtedly, there will be certain organizations, certain venues that make decisions that if you want to be able to participate, you can do whatever you want, take, not take. But if you want to be part of this particular venue, you have to show some evidence of vaccination. And it's really early right now in terms of people thinking through these issues philosophically as to what can or should be imposed versus encouraged versus leaving it to choice, but then having consequences that if you made a certain choice, you may not be able to participate in certain activities freely.
I mean, JB, look, in healthcare, for a long time, we've had the equivalent of that. I had to prove TB immunity, influenza immunization to work in many healthcare settings. We've a long time had those passports for children. They are called school immunization requirements. And because, by the way, school is a congregate setting as well. And so I think it's a very nuanced issue, that there are always going to be settings where people may be looking to proof of immunization or even immunity as a passport. I really doubt we're going to have it for comedy clubs, though. And if you ask me, I wouldn't recommend it, because I could give them all, a test today, and they're in the comedy club, tomorrow, and a few of them in the interval could have begun to express the virus. The fact that they're not viral positive today doesn't mean that they're not going to be viral positive tomorrow. And that's probably about the best we can do in terms of having, designing a process that would do that. So now they're probably still going to have to wear a mask in the club or something like that. But I do think that I'm sure that in Inova as well, that we already have little immunity passports for many people in healthcare. That's what we do.
Yeah. Well, let me turn it to you, Dr. Jones. How do we track who's been vaccinated and that they've come back for their second dose? And then President Burwell, we had a question from one of our friends at the Washington Post that is a tough one. So I'm going to turn to you with that one after after Dr. Jones, your comments about how we're going to track who's been vaccinated and where they are in that process.
Yeah, I think it's going to be a lot harder than it probably would appear. For example, people just simply remembering to do a once a year checkup or getting their teeth cleaned every 6 months. We all forget. And that, as was pointed out earlier, there are going to be multiple vaccines. So you can't have gotten one dose of the first one and then 2 or 3 to 4 weeks. And by the way, those are different numbers. Get a dose of the second one and have any hope that it's going to make a difference. So I am concerned about that being one of the many logistical pieces that needs to be worked out. And it may end up being as simple as a card we hold. Hopefully it would be, as Sylvia, I think, had mentioned earlier, hopefully it would be something electronic. But if we don't have a good way to track it, then we're going to be chasing our tails and potentially wasting some of the few precious doses that we do have.
President Burwell, I don't know if you want to comment on that, and then I can ask the question from our friends.
I think this is why getting to this level of detail is what we need to do to make sure that we can do high quality execution of, it sounds like, very good vaccines coming online. And so what we need to do is figure out, are you going to use electronic health records? If so, how do you get the interoperability that you might need for those? If you're going to do it electronically, are you going to piggyback on the apps that now some have created in terms of where people are? Can you do it through an app? And where are the cases where something will need to be done to make up for, people, elderly who don't have phones, if we're using that kind of technology, and how we work through that. But those are exactly the kind of details that we should be. This is why it is a whole of government effort that is required to get to this level of detail. And it's not just the government, it's the government working with hospital systems, public health systems, the nurses association, hearing from all of these places. That's how you'll get to the best solutions that we can execute fast and extremely well.
Great, thank you. That's great. The question from the audience was, given the level of case incidents throughout the region, both states and the district, shouldn't we be pulling back to the most restrictive status? I guess it was phase 1 or whatever it was that the shutdown status was in the regions. And if not, why not? Any thoughts on that, President Burwell?
So as we've been in this meeting, I think what came through popped up on one of my screens is I think that the mayor, certainly of DC, just has made some additional announcements. And I think one of the things as we think through, thinking through things, and I think it's very important for all of us to not use the language of shut down, lockdown, and that sort of thing, because this is actually a nuanced issue. And facts and context make a very important difference as you move. I like to say at AU, what we're doing is ramping. We're ramping back, and that's dependent on the context, the access to testing, all of these factors. And so I think looking through, and the other thing is we've learned more about what are the things that seem to be working, where is transmission. Transmission in the early parts was very much in those congregate settings. We were extremely worried about steps have been taken in some of those settings, and we don't see as much. We see another kind. And so making sure that the solutions that you're putting in place are the solutions for the problem that we have in front of us and the way that the transmission is occurring right now. And so I think my understanding just from the email that just flew across was that the mayor is taking certain steps. And I think mayors and governors across the country are going to have to think through. But that's why a national strategy and approach is a helpful. I come back to that because you have the standards by which you look at different contexts, your case count, your all kinds of pieces that help guide you and bring in the most relevant data and science that we know in terms of what we're seeing in terms of how transmission is occurring right now.
Right, great.
So if I can add, and I completely agree with the idea that this is a nuanced thing. And so, I mean, the mayor is not rolling us back to phase 1. And I think to do that would require a lot more transmission than what we're seeing now, but we certainly are seeing more transmission, and we see more transmission on our campus now. We had a few weeks where there were hardly any positives, and now every day We have a handful of additional cases, and that's with testing everybody every week and a lot of control on and around our community. So we know that that's because of the transmission in the broader community. But what she has done is said, okay, we're going to have smaller gatherings, you know, both indoors and outdoors. I think we're all recognizing it's winter, and so people are tempted to want to gather indoors because it's colder outdoors, and that's what we like to do in winter. And it's painful, but I think all DC as well as HHS, we're all saying, unfortunately, don't travel for Thanksgiving if you don't have to, and don't gather. And I certainly worry about that with our students. They need to be with family and friends for Thanksgiving. It's very difficult to tell people don't do that. Yet we don't want our students bringing coronavirus to older members of their family, and or going and getting exposed and coming back. But and then I think she's also ordering that some of the businesses close earlier. And there's a lot of controversy around that, JB, but there is certainly the notion that the longer hours may be associated with more transmission. It could be that as it gets later in the evening, people come closer together. Maybe they're drinking more. You know, the kind of activity where you're eating and drinking and you're gathered together. That's where certainly we're seeing a lot of transmission on our campus. Even small groups that just get together to watch a football game or have a small birthday party. We see transmission with that kind of gathering. So it's a shame, but I think that I think it's good that she's taking these steps now, because we don't want to wait. And I think that's something we learned earlier on, you know, in the pandemic, that if you wait until you have very widespread transmission, as we do see in much of the country, that then it's very, very difficult to arrest the rate of increase of the pandemic. So
we had a question about what I'll call marketing against this, to have vaccines be more acceptable more quickly. I'd just like to quickly go around how much should that be the responsibility of the federal government, and how much of it should be or could be the responsibility of other entities, and if it's the latter, what are the sorts of things that we can do? And Joe, you alluded to this, that there are, you know, there's the possibility of using celebrities, a variety of different techniques that are kind of traditional marketing techniques potentially to get the message out. So let me start with you. What comes to mind in terms of things that civil society, businesses can do to increase the interest on the part of folks in taking the vaccine?
Well, I have close to, if not fully exhausted, anything expert that I might share on this topic. But I will say, relative to the business community, trust in business is up. And what you've seen in the course of the pandemic, the way in which businesses have really galvanized to protect the health and safety of employees, coupled with a polarized political environment, is that more and more individuals are looking to their business and their corporate leaders for credible, neutral information on a whole variety of topics. And I would expect that this will be one, and that we will have an opportunity, and JB, the partnership, will likely have a chance to play a convening role in this, to be able to speak out forcefully around the wisdom of participating. And I hope that we're having a conversation about how to deal with the sequencing of getting the vaccine allocated to an overwhelming majority of people who want this, and we're simply allocating on a societally optimal basis, versus having a conversation about, you know, what to do if people don't want it or whether it's required.
Right. Yeah, that's a good observation. We are running toward the end of the time, so I was just going to do two quick things with folks. One is everyone gets to answer with a really short answer, and then I'm going to ask each of you, if you would, to make closing remarks. Before I get to that, though, I did want to thank everyone again, and I'll come back at the end here and just thank each of you again. But it's been a terrific conversation, highly pertinent, highly valuable. I think the synthesis of these perspectives is an expression of what we need to be doing to move forward as fast as possible jointly. So thank you for that. So here's my question. Pick a month. What month in 2021 is the month when folks generally are going to feel like things are better? I'm going to start with Dr. Jones.
Better, I would say by April.
Okay, Joe?
Listen to them. They're the experts.
Well played. I'll come back to you. Dean Goldman.
I was going to say April as well, and for two reasons. I mean, one, that they will actually begin to see a reduction in mortality as people in that 1A group are immunized, and that's going to make an impact, you know, because, but also the sun will be shining, you know, and people just generally do feel better in spring. So it'll be a nice time, I think.
Right. President Burwell.
Actually, I committed to April in the sense that we actually are looking at bringing some of our first-year students back to have on-campus experiences, to do a 5-week block of some of the living part that they haven't. And so April was what I was thinking as well, and have even talked about that in terms of our community.
Yeah, well, that's great. I think it's striking to hear that. Joe, I can come back to you now, and you can say.
Make it unanimous. We've certainly been thinking that springtime is a demarcation point.
That's great. Well, I think that's very striking. I think given the how dire the short-term news looks and how much still has to be done, as we've discussed over the course of this panel, I think it's remarkable that folks are feeling like the April to May timeframe may be one when we all feel quite different about circumstances, and that's good to hear. Let me quickly turn to each of you for any final observations, recommendations that you might make, and thank you again. Dr. Jones, why don't I start with you?
Leadership matters, and I think it's a time for all leaders, elected leaders, business leaders, religious leaders, to take on. We know a lot of things now that we didn't know several months ago, and take on and lead. Encourage masking, encourage vaccinations. It's time to step up and take responsibility.
Thank you. Dean Goldman.
Well, I'm thinking, you know, we have before us a long winter, a lot of transmission, and it's dark. And shining a light is a good response to darkness, and testing is a way to shine a light on this. We can't fight an enemy that we can't see. And so we definitely need to see an increase in testing. And I think the federal leadership will be very important for that. It's not rocket science. This isn't like vaccines, JB. The technology is an old technology. We have the equipment, we have the means of doing it, but we need organization around making it affordable and available.
Yeah, that's great. Thanks very much, Joe.
I would first just thank all of those who have joined, and so many wonderful members of the community that are doing so much to help us through this incredibly challenging time. Resilience is probably the word that's top of mind for me. Getting through this very difficult next several months, while at the same time recognizing that there really is a light at the end of the tunnel. And the breakthrough here will ultimately go down as a triumph for technology, for science, for government and business working together. This is a monumental achievement that if we can just hunker down and act responsibly and demonstrate leadership to get through the next several months, we'll be in a much better place over the medium term.
Thanks. President Burwell.
I'll just first start by just saying thanks and thankful to all our healthcare workers, to those who've been working on that vaccine, to those who stood up and did the trials. Think about all those people who were willing and did it very quickly to do all that. And so I think we're around this time pausing and saying thanks to all the people who were in a very dark time, but for all the people who have made it less dark than it would be, and will make it less dark as we go forward. So one thing on my mind is just that appreciation to all of our frontline workers, for all the essential workers who keep our grocery stores and keep us all going in all of those ways. And then the second thing I would just ask for everyone on this call, I think it's clear, this is actually something where everybody can do something. Everybody can make a difference. And whether that's in the leadership that Stephen was describing, which many of you are in places and positions to do that, as well as what each of us do as individuals and citizens. and get your flu shot.
Yeah, thank you. Well, terrific panel. I want to thank all the panelists again for all that you're doing. Joe, your firm's been a great partner in the effort. Thank you for that. Dr. Goldman, you've been a thought leader on all this for an extended period. President Burwell, obviously, you've seen where this should go, and I would commend everyone to the report that you co-chaired with Francis Townsend that came out recently about the long-term lessons we can learn from all of this. And Dr. Jones, your folks are on the front line every day, so thank you for that. I think we'll leave it with this. We in the piece we wrote this week, we ended it with links to the 3 food banks in the area that folks we would recommend folks consider contributing to this week. So I've asked my colleagues to put those links back up in the chat, and we'll put them out again. But there are some 54 million Americans right now who are feeling food insecure, not insubstantially due to this pandemic. So we may not be able to travel, but we sure can help some other folks. So we would commend that to all of you who can. With that, thank you. Thanks for everyone for attending. Thanks to all the panelists. It's been a great conversation. Thank you.